Welcome to the Life After Whipple project. I appreciate everybody showing up tonight. I'm Greg Adams, a pancreatic cancer survivor and the current team leader. Now, one of the greatest impacts of the Whipple procedure, the impacts that it can have on the body, is on the gastric or digestive system. As Dr. David Kwan mentioned in episode 101, it's not like a kitchen remodel. It's a total tear out down to the studs. But I wanted to point out that not all of the appliances are put back in when you do this rebuild. For survivors like me, you only get back what you can't live without, like a sink and a cooktop. There's no dishwasher, microwave, refrigerator, not even a stove. You have to learn how to live with less. Well, tonight, Dr. Cyrus Piraka, a gastroenterologist at Henry Ford Health in Detroit, Michigan, he will address the impact the Whipple procedure has on the gastric system. He will describe the problems this surgery causes and review therapies for managing them. Dr. Piraka, I'll let you take it from here.
So the title of my talk today is Life After Whipple, Effects on the GI or Gastrointestinal Tract. These are my disclosures that just to let you know what kind of funding I've had in the past. I've had some research support for a different subject from Aries and US Endoscopy, and I've given talks with Boston Scientific. So again, as a general outline of how I'd like to proceed today, I'll start with a little bit of different introduction than has been discussed before, and spend some time reviewing the normal anatomy and physiology of the stomach, duodenum, pancreas, and bile duct. What do they normally do? Where are they normally situated? As kind of a precursor to understanding what types of things you could predict could go wrong after removing certain parts of the upper GI tract. And then, what kind of changes occur after Whipple, and what are some common problems or symptoms that occur after Whipple? And in conjunction, talking about certain kind of known problems and describing them and what types of therapies are available, be they medical, endoscopic, dietary, and what have you. So when I had a chance to speak with Greg not too long ago, I really, as I mentioned before, found it really intriguing, this concept of the need to talk about life after Whipple. And I think it's clearly much more relevant because of a number of reasons. One is people are living much longer after having a diagnosis of pancreatic cancer than before. And so understanding how to deal with life and how to live a normal life as much as possible and enjoy your life as much as possible without the dishwasher, so to speak, or microwave, as Greg put it, I think is really important. Our care doesn't end with the surgery. It's just one part of ongoing care where we have a responsibility to help you who've had Whipple. Needless to say, we talk, these are cancer foundations, but not everyone who gets a Whipple has cancer. There are quite a number of people that we follow that have had Whipples for benign disease, chronic pancreatitis, and with blockages of the bile duct to the pancreatic duct that are refractory, suspected cancers that turn out not to be cancers, precancerous lesions like certain types of pancreatic cysts like IPMNs that are at risk for becoming cancer. May lead to get somebody getting a Whipple, and so that has a different impact on how what our expectations are going to be after surgery. And it's, I don't know if it's I said it's a novel concept in the slide, but to some degree it's something that's novel in the sense that it's not an area where a lot of effort has been made, or a lot of research has been published to truly understand the unique challenges that people face after having a Whipple. And so, as with many things where research is limited, we really have to use rationality, deductive reasoning based on a lot of what I'm going to present to you today, a good fundamental understanding of anatomy and physiology and how disease occurs and how we manage disease in other settings outside of an after surgery setting. So I'd like to start with kind of an overview. And as I was talking with Greg about earlier, when I see people for pancreatic biliary disease, often again prior to surgery, I spent some time with an anatomic diagram, something like this. There's multiple ones that are available. This is just one that I chose that had some features that I thought we could highlight as a means to kind of visually understand an overview of the digestive process. And so, so as a general overview, and again, some of this may be more or less obvious depending on how much you've studied, researched, been involved in this before. So this is just kind of an initial overview. So the upper GI tract really is mouth, esophagus, stomach, and duodenum, the beginning of the small intestine. Mid-gut is most of the small bowel, which is like 22 feet, 7 meters of bowel. And then the lower GI tract is the colon, or the large intestine. But most of what we're going to focus on really is in the upper GI tract. And so once food passes into the mouth, into the esophagus, really the digestive process starts even before you start eating. It's the salivation, creating enzymes, the preparation of the GI tract for food to come in there, that Pavlovian kind of response, so to speak. And once food gets from the esophagus into the stomach, there's a digestive process that I'll describe of breaking down, mixing, getting food ready for the rest of the GI tract before it then enters the duodenum, the small bowel, past a muscle that's not drawn here called the pylorus. And the beginning of the small intestine is the duodenum, which is just this kind of like enhanced C-shaped part of the upper GI tract. This is the end of the jejunum, kind of right where that kind of curve of the stomach is. I don't know if you can see my arrow. And then after food gets initial digestion in the stomach, then it reaches the duodenum where it gets mixed with bile that's made by the liver and pancreatic enzymes that's made by the pancreas that mix with it to be prepared to be absorbed in the small bowel. One of the things I think, I want to highlight kind of as a preparation that was, I'm sure Dr. Kwan kind of discussed it in greater detail than I will, but there's a lot going on in a very small space. There's part of the stomach in this area. The pancreas is right behind the stomach. The bile duct runs through the pancreas. The duodenum runs around the side of the pancreatic head here. There's these large blood vessels, the superior mesenteric vessels here, this vessel or vein and artery that go to the spleen, and one that goes to the liver, the hepatic artery and portal vein. There's all sorts of things going on in a very, very small space that can impact decision-making about how a Whipple has been developed to make it safe and effective and to make things still work. But as I mentioned, the pancreas is mostly behind the stomach. Bile drains through the bile duct, and pancreatic enzymes drain through the pancreas. Bile helps absorb fats and fat-soluble vitamins like A, D, E, and K. Pancreatic enzymes break down starches, proteins, and fats. The stomach is really kind of the beginning of this, the process of, of the location where a Whipple may be affected. And so I'm going to start by talking a little about what the stomach does. It looks like a pretty simple bag where you would think, well, it's a bag and food goes there before it goes someplace else. But there's a surprising amount of things that go on just in the stomach, something that seems like a much more simple organ than something like the pancreas or the liver. I mean, it is still more simple, but there's still a lot going on. This is a breakdown of the different parts of the anatomy of the stomach, so you have a sense of what I'll refer to later in terms of what's going on in different parts of it. The fundus is the top of the stomach. It kind of acts as a reservoir space. The body of the stomach is the biggest part of it here. The antrum is close to the exit. The pylorus is a muscle valve, a circular muscle valve that when the muscle contracts, it closes. When it relaxes, it opens up. So it's like a sphincter valve. And there's also a sphincter valve here right above the cardia between the esophagus and the stomach. The cardia is the very top of the stomach. So these are the terms that we use to describe different parts of the stomach because they have different types of cells, different kind of functions depending on the different parts of the stomach. When food gets into the stomach, it has to distend. Our stomach isn't always as big as it is when food is there. So normally it starts somewhat contracted, somewhat shrunken, and then can distend, what we call a process called accommodation, to allow for food and fluid to get into there. Baseline, most of the time it accommodates to about 1 liter, but of food or fluid, but it can, in many cases, stretch up to 2 to even 4 liters to accommodate a much larger volume of food. And so So, it's pretty remarkable, just that process. And that occurs because there's a complex network of nerves that run through smooth muscle that's in the wall of the stomach that then kind of lengthens in response to signals the stomach gives itself that, hey, food's coming here, let's create some more space. And then it reaches a point where you say, okay, now I'm full, because there's enough stretch on the stomach wall. There's enough kind of internal receptors that tell us that we're full, or hormones that tell us that we're full, versus being hungry. When food gets in there, not only is that stretch, but there's an intrinsic, some people call it a pacemaker, that creates kind of this impulse for rhythmic contraction of the stomach to propel food forward. In a process it's a form of peristalsis, where you can kind of think of this like if it starts contracting from the back to the front, kind of like if you're squeezing the last bit of a tube of toothpaste, contracting from squeezing from one side to the other, that propels things forward. But the stomach propels things forward and back against, depending on the size of food and where you are in the digestive process, against a pylorus sphincter that then closes and opens, and in service of mixing food with stomach acid and enzymes to create something that's called chyme, 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 that then is kind of a partially digested mixture of food and gastric juices to get it ready to be absorbed further downstream. And so this pylorus closes and then opens, and then this chyme can then pass into the small bowel. Things that the most well-described things that break down food are stomach acid. The pH of the stomach can be around 2. Neutral is 7, and 2 is a very acidic environment. So having a part of the GI tract that can tolerate a pH of 2 that has an intrinsic function to protect itself from its own acid is also a pretty remarkable accomplishment. And then there's other enzymes. Pepsinogen becomes pepsin, which helps break down proteins. So it's also part of the breaking down of proteins process. Part of the relevance you'll see is that often part of the stomach, the lower part, the pylorus and antrum, gets removed during a Whipple, and that can affect function. I want to point out kind of along the way that depending on the reason for the Whipple, there may already be impairment or obstruction or blockage of various parts of the upper GI tract already baseline. So if someone has a pancreatic cancer, for example, it may grow enough around the C shape of the duodenum or the stomach to block or partially block the flow of the stomach and already impair the function pre-Whipple. And so although we're talking about normal to post, what is normally happening and then after Whipple, I think it's important to acknowledge up front that often there are some derangements of normal activity because of the effects of the tumor producing hormones and creating obstruction and things like that may already baseline negatively affect or impact the function of the stomach even prior to surgery. So the next couple of slides are a little bit more detail, and there's not going to be a test on the cell types. But it's pretty fascinating, as I mentioned, all the different things that the stomach does to really prime the digestive system. It kind of sets the stage for food and nutrition and nutrients for the rest of the GI tract. I mentioned that there's a highly acidic environment in the stomach in normal circumstances. The surface cells on the lining of the stomach produce mucus. These are called foveolar cells that protect the stomach from its own acid. It also creates a lubricant process to help food kind of pass further down to lower parts of the upper GI tract. There's cells called parietal cells, which are in the upper part of the stomach, the fundus in the body, and they make acid, hydrochloric acid, part of breaking down food and part of killing bacteria, part of like an initial immune system response. They also make something called intrinsic factor, which is a unique substance that helps absorb vitamin B12 further down in the small intestine. There's other cells in the stomach that make pepsinogen, that other part of the digestive tract, that converts to pepsin in the presence of acid and is part of what's breaking down proteins. So part of breaking down proteins in the smaller pieces that become more digestible. Also in the fundus, top of the stomach, not affected by a Whipple in terms of the resection. And then there are other kinds of cells in the stomach beyond those that regulate, that produce acid or produce mucus. And there's what's called neuroendocrine cells, which are cells that create hormones that are part of this regulation process. I've highlighted in red the ones that are in the pylorus, which are absent of pylorus sparing Whipple will be removed surgically. And what you'll see is, so there's G cells, which make gastrin, G-gastrin. And gastrin is a hormone that the stomach makes. Usually when it makes this hormone when the acidity is detected to be too low, a pH is higher than normal. And it's part of what stimulates the stomach to make more acid through a process of stimulating other cells. So it's low acid stimulates this cell to stimulate another cell to secrete histamine to make acid. It's really kind of this beautiful complex process that creates this lovely homeostasis of acid regulation in a normal setting. The D cells in the pylorus do the opposite. They make somatostatin, which suppresses gastrin and therefore acid production. So it's kind of hey, it's too acidic, let's suppress it, right? So this part of that regulation process goes. Fundamentally, what ends up happening is that acid levels are usually there's not as low of a pH, not as acidic as prior to surgical resection. But those are the main cells that leave. All the other cells, generally are intact. Hormones that regulate motility, like serotonin and fluid secretion. There's a hormone in the top of the stomach that's released in the fundus called ghrelin, which you may have heard of. That's part of stimulating your appetite and helps with promoting fat storage. It's a kind of a hot topic of study in the field of obesity medicine. So a lot's going on in a bag at the beginning of the upper GI tract. And then once it leaves the stomach, it enters the duodenum, which is a very short segment of small bowel. Much shorter than the rest of the small bowel, which again is about 7 meters long on average, or about 22 feet. And in the duodenum, there's a number of things that happen. I'll go to the next one first. There's Brunner's glands in the beginning of the duodenum that make bicarbonate to neutralize stomach acid. So we don't have the same lining here to protect yourself from stomach acid. So there's an immediate, hey, let's neutralize this stomach acid with these glands that exist in the duodenum. It's a site of bile and pancreatic enzyme secretions and initial absorption of water, electrolytes, and nutrients like glucose, just simple sugars get absorbed early on in the duodenum. There's a lot going on here, so it doesn't have quite the I'm not going to go into as much detail in terms of the cell types here, because I think the highlights really of the duodenum are related to neutralizing stomach acid, but also, its role in absorbing certain vitamins, which I'll describe later. And it's where the pancreas and the bile duct drain. So there's an opening within the duodenum. The area is called the ampulla of Vater, and there's a muscle valve called the sphincter of Oddi that regulates flow in response to signals that the GI tract gives itself. And again, I'm not going to go into those specific hormones that stimulate it, but there are different hormones. Secretin is one of them that you may have heard of, and that stimulate kind of the release of enzymes from the pancreas, release of bile from the liver, contraction of the gallbladder to spill bile as part of the digestive tract. And I'll kind of explain more detail how those things function in the upper GI tract. But in the duodenum, this is really where you have bile and pancreatic enzymes that come in, and is this second part of priming food to be digested in all those feet of small intestine. So bile, I'll describe in detail how it works to help with digest fats, and pancreatic enzymes, how it breaks things down. And again, this is, the Whipple is a removal of the entire duodenum and the pancreatic head. Now, the pancreas has, this has been, I know there was a nice talk about its effect on blood sugar regulation. The two main functions of the pancreas include endocrine functions, which primarily making insulin as well as some other hormones for regulating blood sugars, and what's called an exocrine function, which is this creation of digestive enzymes. The pancreas has these lobules. It's kind of illustrated here as this kind of rounded off edges. And these lobules are called have these cells called acinar cells that create digestive enzymes. And these enzymes are secreted as a fluid that start in these kind of clusters of, kind of a cluster of grapes, not exactly lobules, that then kind of come together and become confluent through these side branches. These side branches that go out to the periphery of the pancreas go to these lobules where the enzymes then come together and they flow in this direction from on this image from your visual right to the visual left, or from the person's left to the person's right. And so they flow down this main duct, the pancreatic duct, out of this opening, which you'll often see multiple names. The area is the ampulla vater, the muscle is the sphincter of Oddi, what protrudes in the bowel is the papilla. It's very confusing because there's three different names that kind of describe sort of the same area, but that's really the exit of the pancreatic duct. And the bile duct also, and so that's the main kind of function of the pancreas. So these enzymes, lipase is one you may have heard of, that helps break down fats, proteases for proteins, and amylase for breaking down starches, amongst other types of enzymes. And so, that's where the pancreas fits in terms of its function in the upper GI tract. Now, I will also say as an aside that, as I'd mentioned before, with regards to the stomach, the pancreatic function is often already compromised prior to a Whipple. If there's a cancer in the pancreatic head, an adenocarcinoma, the most common one where people end up getting a Whipple, arises from the duct itself, from the glands in the duct itself, and will cause an obstruction of the pancreatic duct. And what you'll see on imaging, a CAT scan or an MRI or an endoscopic ultrasound, is that what you see is you'll see a mass, and then above the mass, or upstream, because the flow is kind of going from the visual right to left on this image, you'll see the duct become dilated. And the reason the duct becomes dilated is because these lobules are still trying to make digestive enzymes, and they're still trying to flow out into the bowel to help with digestion. But if it hits an obstruction, that then leads to kind of a back pressure. And the way your body accommodates that back pressure is to dilate the duct out. And then over enough time, when you have an obstruction, you get atrophy or thinning of the gland. And so it's not uncommon for people to present with pancreatic cancer or chronic pancreatitis and duct obstruction already with some pancreatic dysfunction, maybe a presentation with diabetes as a presentation because there's enough atrophy, or maybe oily stools or weight loss in part related to not having enough digestive enzymes that come out. So even before Whipple, often the function of the pancreas very, very frequently is already often compromised with rare exceptions. And then the bile duct really acts as a transport tube between the liver. So the bile is not made in the bile duct, it's made in the liver as a breakdown product of red blood cells, or recycling product of red blood cells. And the gallbladder is just an extra storage organ for bile. And the bile duct brings bile from the liver to the small bowel through the same opening, regulated again with that muscle valve, the sphincter muscle valve. But anything time you hear a sphincter muscle, it's just a circular muscle that when it contracts, it closes because it shrinks. When it relaxes, it opens up. And bile is involved primarily in absorbing fat by making something called micelles. This is a kind of a diagram of a micelle. A micelle is any structure where you have, in this case, the fats and fat soluble vitamins have difficulty traversing the cells of the small bowel to actually be absorbed. So to aid in absorption, they get surrounded by these structures made from bile and bile salts, where one side of it is hydrophilic, meaning it has an affinity for the water that's in the digestive tract, and the other side is hydrophobic, or lipophilic, which means it's more attracted to fats. And so these things kind of then meld with cells to help them get absorbed in the small bowel. So bile, its main function really is an absorption of fats, and then by extension, fat soluble vitamins. So, if there's a disruption or obstruction of the bile duct, that often occurs even often you have an obstruction of the bile duct prior to the Whipple. So sometimes the presentation that people have with pancreatic cancer or chronic pancreatitis is related to an obstruction of the bile duct, which may be, again, back pressure leading to, on imaging, a dilation of the duct, but kind of reabsorption of bile into the bloodstream, which can then deposit in the skin and make jaundice, or be excreted in the urine and make the urine very dark. Bile is what makes your stools brown. And so people can often have light colored stools as a result of not having enough bile that comes out, and have, deficiencies of certain fat soluble vitamins ahead of time. Now, after a Whipple, this may be, this sphincter muscle may be disrupted, and you may have increased bile flow to the duodenum, or to the small bowel. But as it turns out, although we always worry about that causing problems, your body's incredibly smart and has overall tends to increase the amount that it absorbs in the small bowel to compensate for increased flow. And so there's all sorts of built-in mechanisms to accommodate or account for problems, disease processes, and I think these exist for a reason, because these are the things that confer survival benefit. Being able to adapt to changes from the perfect norm to any disease state. So where does this fit with the Whipple? So remember, this is very, very complex, and what gets removed in a conventional Whipple versus a pylorus-sparing Whipple is usually the antrum. It's hard to tell if this is intended to be a pylorus-sparing. It looks like it's kind of cutting it down the middle, right through the pylorus. It's usually the antrum, which is not exactly drawn here, but kind of antrum, the entire duodenum. Before, this is the beginning of what's called the jejunum, the entire duodenum, and the pancreatic head, and the bile duct and the gallbladder. And what that leaves is, now you've got this cut edge of bile duct. You have this cut edge of pancreatic duct. You have this cut edge of stomach, and you have this cut edge of small bowel. So how does it get reconstructed, put back together, as Dr. Kwan was describing before, so that things can still function? Well, the bile duct, what's done is a loop of small bowel is brought up and then connected to bile duct and pancreas, and the stomach is connected to that loop as well. And ideally, it's timed so that since you lost that sphincter muscle, the timing of the flow of bile and pancreatic enzymes as it reaches this part of the stomach where food is coming through without any slowdown from a pylorus that's gone is adequate for the function of bile and pancreatic enzyme to be effective in the digestive process. So again, the duodenum is completely gone. Most commonly, the pylorus and antrum are gone, so there's no more of that break or slow down of the stomach before it exits the stomach. Much of the pancreas is out, which may be really significant, as much of the pancreas is commonly already atrophied prior to surgery. Part of the bile duct and gallbladder removed, you lose that sphincter muscle regulation, as I mentioned before. And so what problems could that lead to? Well, bypassing any initial adverse events that occurred just immediately related to surgery at the time, there are some long-term surgery-related problems that may occur as a consequence of these reconnections that occur. Any place where you have a reconnection, there's a risk of there being that healing process where it's connected, intended to be open, but you're creating an injury in the bile duct, for example, and an injury in the bowel where you're connecting it to, or the pancreatic duct to the small bowel, or stomach to the small bowel. You're creating an injury by cutting it, and you're sewing things back together, but there's going to be increased blood flow to the area. What your body does anytime there's a cut or an injury is that there's going to be some deposition of scar tissue, some creation of scar tissue, and you hope that connection, what's called an anastomosis, stays open. But occasionally you can have this connection between the liver and bile duct and the small bowel stricture down and be scarred down or narrowed, and that can cause an obstruction of the bile duct, jaundice, an infection in the bile duct. That's what cholangitis is. You can have an obstruction of the pancreatic duct to the small bowel. This is very difficult to deal with technically, and that can cause pancreatitis or abdominal pain from an ongoing obstruction of the pancreatic duct. You can have ulcers in the stomach or the small bowel. Now, typically, if you remove the antrum, you're removing cells that these G cells that stimulate acid production. So, but occasionally you remove it thinking, the surgeons remove it thinking they remove all of them, but maybe there's a sliver of antrum with enough G cells to stimulate acid production that then leads to ulcers in the stomach or the small bowel where it's connected, because you no longer have as much of a protection, especially in the small bowel, losing the Brunner's glands for bicarbonate deposition, for neutralizing stomach acid, all these things that are kind of coordinated to make things work smoothly. You do your best to avoid problems like this, but occasionally ulcers can happen. Scar tissue can lead to bowel obstruction. You can have hernias at the sites of incisions that relate to surgery. And how often, this is one area where there is surgical complications, short and long-term complications. There is much more data, much more literature related to that, much more time spent examining that. And there was a study from 2020 that looked at this, a pretty good sized study. where they define long-term surgery problems as being greater than 3 months out after Whipple and not related to any cancer recurrence. And they had 628 long-term survivors that were able to be recruited in the study retrospectively, put in the study retrospectively, with a follow-up of at least 4 years and survival of at least 5.5 to 6 years. And almost a third of people had at least one long-term complication. Now, the most common was a hernia, but 8% had strictures and infection of the bile duct. Almost 6% had pancreatic problems, pancreatitis. 4% had bowel obstruction. 3% had peptic ulcer disease. So these do happen, and they can be consequential and lead to symptoms and problems as well. And almost a fifth of them required some intervention. And nearly half of the time, the intervention was surgical. And they found that the things that kind of predicted more likely having long-term surgery problems as being overweight, having had an infection immediately after surgery, or a longer length of stay in the hospital, pylorus preservation, open surgery versus robotic, things that that make some sense that may be related to more problems after surgery. So how do we manage these problems? A lot of this is where I most commonly get involved, diagnosing and managing short and long-term mechanical problems. These are more kind of mechanical issues related to kind of the surgical reconnection. So biliary strictures, we can often do a procedure endoscopically where we put someone to sleep and pass an endoscope through the mouth, esophagus, stomach, and reach this level, and then dilate or stretch open this connection site. On the pancreas side, we can do that too. It's technically often much more difficult. There tends to be a lot more scarring, but we can do that. And there's some tricks that we can do to be effective when it's more challenging. Ulcer disease, often it's a matter of managing medically, assuming it's related to acid production with strong acid control of acid production with medications like omeprazole and similar medications. If it's related to poor blood flow to that area, related to how it's connected, often tincture of time works without the need for revision surgery. Small bowel obstruction depends on the severity, but may require surgery to fix. And hernias, if they're bothersome or a higher risk, can be managed surgically as well. But I suspect a lot of people who are watching this are more interested in kind of other common longer-term symptoms and problems, not necessarily related to mechanical issues or immediate surgical issues. And a lot of these symptoms, they're common GI tract symptoms where people seek care from a gastroenterologist, but there's very specific reasons why people who have had a Whipple may have this subset of symptoms: early satiety or fullness, nausea, vomiting, diarrhea, steatorrhea, that's oily or greasy stools, bloating, fecal incontinence, having accidents, weight loss unrelated to cancer. And so, I guess the question is, if you've had a Whipple and have these symptoms, why might these occur after a Whipple? And there's a few things, and this talk is by no means going to be 100% comprehensive, but hopefully an overview of the main things that can cause it. So one cause may be that the stomach empties too slow. So sure, without a pylorus preserving Whipple where you take out part of the stomach, you would think that, okay, there's a bigger opening out of the stomach, it should empty really quickly. But that's not always the case. After stomach surgery, there can be something called gastroparesis, where that motility, that kind of peristalsis contraction, forward propulsion becomes impaired. And that could be related to nerve injury, related to a cancer, an underlying cancer, vagal nerve injury, or related to surgery as a necessity as part of removing a tumor. Losing the duodenum loses a hormone that promotes forward motility called motilin. High blood sugar is related to diabetes that often occurs in this setting, can also cause slow emptying of the GI tract in the stomach. And if pain medications like opioid pain medications are part of what's needed to manage pain, that can also slow down the GI tract. And part of this also, this gastroparesis process, is not just that things aren't emptying very well, but you lose other parts of the function of the stomach, like accommodation, relaxation of the stomach to allow for space in the stomach. So feeling full or bloated or uncomfortable or nauseous because it's not stretching enough to take in the food that you're eating can lead to pretty significant symptoms and can be very difficult to treat. And so the other side of this, and the question that I think, okay, so if that's what's going on, how do we manage it, is complex. It's multidisciplinary. There's no one answer as to how to treat this. Anytime you see something that has multiple different medications or treatment options to treat it, that usually means there isn't one really good thing, that every option is okay, that works to some degree for some people or a subpopulation. I don't personally usually medically manage gastroparesis. I usually get involved with certain endoscopic procedures in a different population, that not a non-post-Whipple population. But it can be very, very challenging to treat gastroparesis because you can't restore that normal nervous system function of the upper GI tract after surgery or after a cancer diagnosis. So it's a matter of trying to managing symptoms as well as possible. That's using certain medications that may promote forward propulsion through the GI tract, metoclopramide, otherwise known as Reglan, erythromycin, domperidone. There's other medications that are newer that may or may not be effective in this setting. May help. Often managing diet is the most important and most helpful component to this. So with medications and an overall kind of management of gastroparesis, usually I'll involve a GI motility expert. We have motility experts at Henry Ford that we involve, Dr. El-Sheikh and Dr. Ginnebaugh. Having a dietitian involved is really, really, really important for gastroparesis and really for just about everything after a Whipple. And often what the types of education that I'll be given about gastroparesis management involves changing how you eat. Instead of having the 2 or 3 big meals, having smaller volume frequent meals, 5 or 6 meals a day, so you don't kind of overload a system, you don't distend things too much. Avoiding foods that are more difficult to digest, fibrous, uncooked fibrous vegetables, for example. Being careful about not having too fatty of a meal. Fats can slow down the GI tract. Chewing well, starting the digestive process early. Now, exercise can help promote GI motility and can make just trying to make you feel better overall if you can manage it with the symptoms. And managing mental health, any mental health issues. It's an unbelievably stressful. I can't imagine the level of stress that must be involved in every element of life. If you're watching this talk as someone who has had a Whipple, who is anticipating a Whipple, stress with a diagnosis, that's a scary stress about what's going to happen at surgery, what's going to happen with chemotherapy. Am I going to tolerate it? What are the scans going to show? I have this symptom. What does it mean? There's a lot that can have a negative impact on GI tract motility that can just be kind of additive and make things much, much more challenging, much more difficult. Things that I can't personally understand, but I can only imagine must make this far, far more challenging than the simple mechanical, this is the problem, we're going to do this, that can have an impact on GI motility. What about the other side of it? What if it empties too fast? This is so-called dumping syndrome. There's actually 2 types of dumping syndrome. And so whenever people use that term, I always try to kind of clarify that it's more than one thing. So dumping syndrome occurs if you lose part of the reservoir of the stomach and things empty too quickly. This can create an osmotic effect where it pulls too much water into the bowel. So you have things that keep water in rather than letting them be absorbed into the GI tract. And that can lead to diarrhea, fullness, cramping, vomiting that can occur within half an hour after a meal. But it also can affect the timing of absorption of sugars if things are emptying too quickly, especially, simple sugars tend to be absorbed much more quickly because they don't need to be broken down. Glucose, for example, any glucose can be absorbed very, very quickly. And so here's kind of a nice pathway that I found that I think is a nice way to explain it. You have a meal, things empty too quickly, and on one arm here, hyperosmolar jejunal chyme. That just means you have food that keeps water in the small bowel. Chyme is that product of food that's partially broken down in the stomach. Intraluminal fluid sequestration. That just means it keeps fluid in the lumen, in the bowel, rather than allowing it to go into the bloodstream. So decreased blood volume if fluid doesn't make it into the bloodstream, which may lead to hypotension or low blood pressure, lightheadedness, rapid heart rate, tachycardia. It may also, having a lot of fluid in the intestinal tract may lead to bloating from just a pure volume situation that can lead to abdominal pain and delivery of more fluid that can be managed, or other things that get delivered too quickly before they can be absorbed and can lead to diarrhea. There's hormones that can be released too early that can also increase GI tract motility and cause some of these symptoms. And as I mentioned, sugar being absorbed too quickly can lead to this really, roller coaster effect where you get sugar delivered into the bloodstream too quickly before what insulin that you have can be released to counter it. So you get this upshot in blood sugar that can cause dysmotility, nausea, vomiting, bloating, discomfort. And then you get a late response where insulin catches up, and then boom, your blood sugar drops, and you get weakness and flushing and sweating and dizziness. So it can just be a really big roller coaster ride. And all these things can kind of be, work together to from multiple different mechanisms to create this really uncomfortable and alarming set of symptoms. Managing dumping syndrome often, again, I'm a big proponent of dietitian involvement. I think they're incredibly valuable in this space. But similarly, having frequent small volume meals, taking foods that may be slower to absorb, high fiber diet, high protein, more complex carbohydrates, avoiding simple sugars and sweets that may cause these shifts in blood sugar. There are medications that can be done to kind of limit this rapid emptying effect, like somatostatin, that's not often used but could be used. So there's some medical options as well in this setting. One of the more common things I think that we recognize and address in the setting of a Whipple is the presence of steatorrhea, or pale, greasy, foul-smelling stools. And this occurs as a result of losing that exocrine function of the pancreas, the enzyme production of the pancreas. Now, as it turns out, there's an unbelievable reserve that the pancreas has, partly for insulin and the endocrine function, but also for enzyme release. Most people would estimate that you need to lose up to 85-90% of pancreatic tissue before you would exhibit signs of pancreatic insufficiency. So you need to lose a lot. Your pancreas has a tremendous reserve to be able to keep up with digestion in terms of enzyme productions. So if you're getting a Whipple, well, in theory, the removal is a third to a half of the pancreas, maybe give or take, depending on how big of how extended the Whipple is, how much of the pancreas is removed. But most people who get a Whipple already have some loss of pancreatic tissue, as I alluded to before, because of duct obstruction from a tumor or scarring and atrophy or thinning of the gland as a result of that. So there's already kind of a starting point of not having as much pancreatic tissue, and many people end up getting a Whipple. And as I mentioned before, this can affect multiple portions of digestion, but the fat part of it seems to be affected more than everything else, as the lipase, the fat, and the enzyme to break down fats gets broken down more easily in the small bowel, whatever is released. And so it tends to kind of have the most loss of effect of that function, which can lead to weight loss, fat soluble vitamin deficiency, and so on. Diagnosis of it, there are tests you can do. You can measure how much fat is made in the stool. It's very, very rare for me to order a quantitative fecal fat, because that's a 72-hour collection of stool you keep in your refrigerator and bring to the lab. It's a big ask for someone to do that, to quantify it. There are other tests that check for pancreatic insufficiency, a more one-time stool test called fecal elastase that measures pancreatic enzyme that gets secreted that don't get reabsorbed in the small bowel. But often you don't really need that. It's more of a clinical diagnosis. If somebody has symptoms of diarrhea, maybe some oily stools, and have had a Whipple, and you see that they have pancreatic atrophy, it's high enough likelihood that this is going on that I often don't think testing is really necessary. And treatment it's fairly straightforward. Pancreatic enzymes are readily available that contain these components, pancreatic lipase, amylase, different proteases, to help with digestion, to help replace what's lost of the pancreas. So this is at least something that's kind of directly replaceable. And as such, part of that management involves understanding how to take the enzymes optimally, taking it with food to try to time it as if your body was naturally making pancreatic enzymes. For a longer meal, potentially spacing out, taking more than one pill throughout the meal, adjusting how much you take, potentially depending on how fatty a meal, really kind of adapting mostly to the fat content of the meal, even though there's other enzymes that are part of it. And as such, making sure that there's plenty of fat digesting enzymes in there. And I often will start with a higher lipase unit component pancreatic enzyme, usually 36,000. and it's a 1 or 2 depending on the type of meal or snack that's used. Often you'll hear recommendations of having a low-fat diet because you worry too much fat will then lead to fatty stools, but there's a risk there that of getting inadequate nutrition and weight loss. If weight loss is already an issue, that cutting out fats entirely or to a large extent can really be detrimental. So it's likely better to maintain a fat content in your diet, but just simply adjust the amount of enzymes that you take with it. There's another common consequence of any bowel surgery, but that can occur after Whipple, called small intestinal bacterial overgrowth, or we sometimes just call it bacterial overgrowth. The concept of this is that normally we have, this what we call a microbiome that is a very robust population of bacteria that reside in the colon, in the large intestine, and it generally doesn't get into the small bowel. And these bacteria, it's very complex what their role is. They are part of our digestive process, but if you have surgery and need disruption of GI motility, bowel surgery, GI motility disruption, then you can have this bacteria kind of find its way higher up in the GI tract because it doesn't get cleared as well from normal motility. And when bacteria make its way up into the small bowel after a Whipple or any other small bowel surgery or bowel surgery, the bacteria can then digest these nutrients early and through a complex process lead to gas production, bloating, diarrhea, flatulence, even incontinence. And can be very alarming. And as you may be kind of recognizing, there's multiple shared symptoms between these different processes that can occur after a Whipple, and teasing out which is which can sometimes be difficult. There is a breath test called a glucose hydrogen breath test that can tease this out. Often, quite frankly, it's a clinical diagnosis of which sometimes ends up being best guess based on what symptoms are, and trial and error. And trial and error in this setting is not as unappealing as in other settings because usually the trial is something that's fairly benign, pancreatic enzymes, antibiotics that don't have as much of a systemic effect like rifaximin. But sometimes this can be troubling. You treat with antibiotics, it works, people feel better, and then you need to repeat treatment. So it's not unusual for that to have to occur if you can't kind of treat the underlying problem that led to small bowel bacterial overgrowth. But it can be very disruptive to the GI tract. There's another process that is commonly kind of described in this setting that I think is probably overstated, and that's bile salt diarrhea. I mentioned before that the exit of the bile duct has a sphincter muscle to regulate flow of bile. After surgery, bile can just be delivered continuously through the upper GI tract. And in theory, or in reality, that too much bile that makes its way to the colon these salts can then increase the amount of fluid in the bowel, kind of act as an osmotic and keep fluid in the bowel, or as an irritant and keep fluid in the bowel, multiple different mechanisms, and then lead to watery diarrhea at night, sudden diarrhea, bloating, soiling, and incontinence. And so sometimes you'll see people using bile salt binders like Welchol or cholestyramine or things like that to bind these bile salts to kind of prevent them from having an effect in the colon. Part of the reason why I tend to avoid that in this setting is that if you use these bile salt binders for too long, you can end up depleting the amount of bile salt you have, which can then cause diarrhea from a different mechanism of fat malabsorption, kind of not having bile make it there at all. I don't think that happens terribly often, but it's still a concern. And absent having any diseases in the lower part of the small intestine, usually the body is very good with enough time of upregulating how much bile gets reabsorbed. So although this gets described often, it's something that I tend to reserve as kind of either something that's transient immediately after surgery, that it's a transit period of time, or something that I would consider kind of lower on the list of possibilities as a cause of diarrhea. And then, as mentioned, you can have vitamin deficiencies from multiple different mechanisms, partly due to what the duodenum and jejunum normally absorb: iron, folic acid, zinc. One study found a zinc deficiency in 69% of people after Whipple, and selenium deficiency in 56%. copper deficiency. You can have vitamin deficiencies from not being able to digest fats from pancreatic insufficiency, vitamins A, D, E, and K. Or it can be related to kind of that timing of when bile and pancreatic fluid meet with food to whether it actually is effective in absorbing and digesting and absorbing food that comes through. So multiple different mechanisms where vitamin deficiencies can occur. And as I mentioned before, this is an area where I often will recruit an expert, a dietitian, to be involved to assess and manage this because it's really their focus a lot more than what a gastroenterologist. We all kind of have our different roles in managing these symptoms. This is a really nice table I cribbed from or grabbed from an article that was written by a couple of dietitians back in one of our journals from over 10 years ago that kind of summarizes some of the nutritional complications that can occur after a Whipple, pancreaticoduodenectomy, gastroparesis, slow emptying, dumping, fast emptying, in not mixing food very well, leading to nutritional deficiencies, fat malabsorption from pancreatic insufficiency, diabetes, and all the different consequences that can occur from that. And I won't rehash this because I tried to go through them in some detail, but I'm leaving this table in case someone wants to pause and take a look, because I just thought it was a really nice summary. And I really wanted to credit the authors of this study because I found these dietitians to be incredibly helpful in understanding some of the minutiae in terms of what they do and what their role is in managing things after a Whipple. And before I wrap up, I just want to acknowledge a few things. There's plenty we don't know about life after Whipple. Our knowledge is fundamentally limited, as is true for everything. There's always kind of we have to acknowledge there's only so much that we know, and there's a lot that we don't know. The unknown unknowns, right? Managing diseases after a Whipple, like gastroparesis, even though we're adapting medications and strategies that we use for gastroparesis and other settings, may be different in this circumstance of having had this kind of surgery versus managing diseases like gastroparesis and other things in people who have not had a Whipple. So even though we kind of transfer similar ideas for rational reasons, there still is likely some difference for things that we know or often we don't know. Another thing that I think is important to acknowledge, there's a lot of common GI tract disorders that can occur in anyone. So I focus on the things that are specific to Whipple, but common things being common: irritable bowel syndrome, non-ulcerative dyspepsia, functional abdominal pain. These things that are disorders of motility, stress-related, depression-related, medication-related, infection-related, these things can occur from multiple different mechanisms. They can happen in anyone. They can happen in someone who's had a Whipple. It can happen in someone who's not had a Whipple. I think it's important to acknowledge that not everyone who gets a Whipple is the same either. It's not a monolithic thing. People get Whipples, as I mentioned, because of cancer, but they get it for different kinds of cancers. Pancreatic cancer is different than ampullary cancer or duodenal cancer. Pancreatic cancer is different in someone who has altered anatomy, who has a variant anatomy of something called pancreaticoduodenectomy, where they don't have chronic obstruction in the main duct. Not everyone has duct, so not everyone has duct obstruction prior to Whipple. Not everyone who gets a Whipple gets chemoradiation, although it's very common. And we didn't even talk about radiation enteritis or radiation-related phenomena as part of our talk, because it's not really the main focus of what I wanted to talk about today. People get Whipples for non-cancer causes, as I mentioned, and they may or may not have duct obstruction, which may or may not affect, post-Whipple pancreatic function, for example. I also think it's important to acknowledge, as I think I've alluded to multiple times, we really need a multidisciplinary team. You've heard me plug dietitians a lot. I think they're very, very important in this field, in this area, and often underutilized. And that's part of the reason I'm saying this often, is I really think that they're underutilized. This is an acknowledgement that people that are gastroenterologists, even though the title seems to imply that we know something about diet and nutrition, it's often not true. It's often there are certain things that we're experts at, but the details and the degree that a dietitian can go in is often far more extensive than what we have the capability or training to do. From many different reasons, managing mental health, physical health, being active as much as possible is also very important. These are these things kind of cycle together, right? You have symptoms, it affects your outlook, it affects your mental health, it affects your ability to be physically active, it affects your weight, and all these things kind of interact. So it's clearly not something that's simple, it's very complex. You need GI motility experts. I'm not one of them, but I often use our team of experts in the right setting when people have motility problems. Surgeons, obviously critically important, endocrinologists who recognize the difference between this type of diabetes versus type 1 and type 2 diabetes are important. Oncologists who often manage immediate complications or related to chemotherapy, radiation oncologists, related to radiation, medical pancreatologists, and occasionally therapeutic endoscopists like me get involved for certain elements of care after Whipple as well. But really have to acknowledge we're fundamentally lacking research and evidence, and we can and should do better in the future. You all deserve it, and I don't think care. I don't think this is a controversial statement. It should end at, okay, you had your Whipple and your chemotherapy. Okay, good luck. That's clearly not adequate, clearly insufficient. And I think at least recognizing and acknowledging that's very important. And that's part of the reason why when I had a chance to talk to Greg about this, I just was really, really kind of inspired. And I'm even getting chills just thinking about it, because I think, my goodness, it seems so obvious when you say it out loud, but it's not obvious until someone says, hey, this is important. This is really something that we need to focus on. So this is something that there's clearly a need that's not being met. So I really, want to, thank you for doing this, and thank you for inviting me. Thank you for listening to me. I hope it wasn't too boring or too much in the weeds with minutia. I hope it had something useful or something worthwhile for you. And again, I genuinely, sincerely thank you for involving me in this really aspirational and beautiful project. Thanks again.
I actually just sent in like 5 questions.
Yeah, do you mind if I look at them and kind of see what I can answer?
Absolutely. Yeah. If any are relevant, please skip it.
No. I mean, no. I think that's the point of this, is really to have a chance to kind of talk it out and think this through. So the first question you ask is it normal to eventually lose the rest of the pancreas, or is that for rare situations? So there's different ways. So I mentioned the fact that prior to Whipple, again, depending on the mechanism, what led to getting the Whipple to begin with, it's not uncommon for people to already have atrophy or thinning of the pancreas baseline. The degree of atrophy varies depending on the situation. And part of that has to do with, the accident of timing of when things get found, right? So, for example, if somebody has a very small cancer that happens to be right by the bile duct and creates jaundice, to where it's found when it's very small and very early, it may be that in the process of where that affects obstruction of the pancreas, thinning of the pancreas duct dilation may be earlier. And so after Whipple, there may be a fair amount of pancreas that's preserved. Part of it also may be if a tumor is located closer to the exit of the bile in the pancreatic duct versus kind of more in the neck, the amount of pancreas that removed may vary as well, right? So there's a lot of variables that can occur. Now, let's say, to hopefully answer what I think you're asking, let's say you have some preserved pancreatic tissue and you get a Whipple. If the question is, will you continue to lose pancreatic tissue thereafter? The answer is, I don't know. And part of the reason I want to be honest with you about this is because I think it's probably an overly simplistic way of viewing things to think it's purely main duct obstruction that leads to atrophy, right? So the way I think things through is things are trying to flow, they're blocked, they can't flow, the duct gets dilated. Eventually, the body's like, why am I bothering to make these enzymes? They're not going anywhere. It becomes atrophied and thinned out. I mean, that's obviously kind of like an overly, simplistic way of looking at it. But let's say you get a Whipple, you have preserved pancreatic tissue, and that surgical connection site is open. So I'm going to exclude this circumstance of, if there's scarring of that site, that'll produce further atrophy and so on and so forth. Let's say it's open. The reason why it's difficult to know what's going to happen over time is that it's not uncommon for someone to already have some changes of what's called chronic pancreatitis, even if there's not tremendous atrophy. So it may not be the main duct, but there may be side branches that have some scarring or inflammation. that's chronic that could lead to progressive loss. That being said, I think that it's much more likely that if you have a fair amount of preserved pancreatic tissue going into Whipple that is still there afterwards and there's no ongoing duct obstruction, then you'll probably maintain a decent amount of pancreatic tissue over time. The people that I've seen who are many years out from Whipple, they'll commonly have thinning of the pancreas. And sometimes I can go back and look at images and see where the pancreas looked before surgery, but often I can't compare. So it's hard for me to know the answer to that. I think that would be an interesting study to say, let's look at people who are survivors of pancreatic cancer or who are survivors of getting a Whipple for whatever reason. And there's ways we can quantify through artificial intelligence, through even just kind of programs from radiology, pancreatic volume before and after and over time. People often get repeated scans as well. And then compare that to ductality. I mean, this is a great study idea. Honestly, like I'm going to write this down because I think this is something that would be very interesting to study. But the most honest answer is I don't know, and I think that I don't know not because I just don't know, but I think I don't know because I don't think that it's known. But I'll certainly look it up. So I'm actually going to write this in. So one study is a great idea.
Yeah, that's something that I think about a lot because I had the tail of the pancreas was preserved in my first Whipple. But then we found out that the cancer cells had spread to the margin where the cut occurred. So they knew there were additional cells. And the tail of the pancreas, the cells in it, over the 4 months we had to wait to have the second Whipple, started to metastasize. So I ended up with the 2 Whipples and having total pancreatectomy. And I know of a gentleman who just had his second Whipple a week and a half ago, also at Henry Ford. He had his first Whipple procedure in 2016, and then eventually found the cancer had come back in the tail. But that raised an issue, and I was asking around, how often does this happen? Does the pancreas that's left behind also become cancerous? And I couldn't find any data on that. But everybody that has the Whipple always has in the back of their mind wondering, is it going to come back in the rest of the pancreas?
Yeah.
But you're right. I had like 20% of the tail remaining, 20% of the full pancreas remaining. And it did pretty much all of what I needed to do for digestive enzymes and insulin. That little puppy really worked hard and did a good job.
You brought up some very interesting points as well. I'll kind of address part of that before going back to the other collection of questions. I think they were really good questions. What is the risk of a new cancer forming elsewhere? And I think I would think of that. The way I would think of that is, why did the first one occur to begin with, right? So if it arose because of certain types of pancreatic cysts, IPMNs, for example, and there's other ones that are there, those are people that we pay really close attention to on follow-up. Are these cysts growing? Are they enlarging? Because those are the ones that can convert to it. If there's some other reason, some hereditary reason why someone may get pancreatic cancer, familial pancreatic cancer syndromes, for example, is there something else? Is there something that makes it more or less more likely, to get another cancer? And what is that time frame of that happening? If it took 60 years to get the first one, does that mean it's going to be 60 years in the other one, or is there some trigger that's occurred, or some change that occurs later in life, or some, so it's a difficult question to answer, and one that I also don't know if it's quantified either after surgery. This idea of a coexisting cancer or like a second cancer that's unrelated to the first one, but I can understand why. I can appreciate that would be in the back of somebody's mind after going through something like this. The second question is, if you've had or are prone to having pancreatitis, are you more likely to get pancreatic cancer, or is it unrelated? There is an association known, chronic pancreatitis. Chronic pancreatitis is it's a structural change of the pancreas that leads to scarring, fibrosis, often either obstruction in the main pancreatic duct or side branches, or chronic inflammation. Sometimes it's difficult to diagnose accurately. Our diagnosis system for use is most commonly endoscopic ultrasound, and there's a whole host of criteria called the Rosemont criteria that actually help validate those criteria in some of the earlier studies, but then nothing's perfect. Chronic pancreatitis is associated with a higher risk of pancreatic cancer, although the risk is still low. It's higher risk than baseline, but low, but still fundamentally low. If you have pancreatitis from gallstones, for example, I'm not aware of that conferring a higher risk of pancreatic cancer. I think if that inflammation leads to scarring and leads to chronic pancreatitis, it's fair to assume that that's probably associated with a higher risk of pancreatic cancer, but still low. And so in terms of a single episode of acute pancreatitis as a cause, no. The one exception I would make is if someone is at risk for pancreatic cancer based on age or genetics or some other background, and they get pancreatitis, when we evaluate them, this is all pre-Whipple, obviously. When we evaluate them, one of the things that's primary on our minds is this pancreatitis a consequence of a small cancer? And I'll look for what's called a transition point. So looking at imaging very, very carefully, very, very carefully. Is there a point where the duct becomes dilated upstream of something, even if you don't see a mass? That should trigger you. Maybe there's a very early cancer there. And sometimes I've diagnosed 6-millimeter cancers before with that in mind, which is, if you're going to diagnose it, you want it as early as possible. Or the other circumstance where people get pancreatitis that may be precancerous is IPMN, this kind of cyst lesion in the pancreatic duct, the pancreas, that arises from like tiny polypoid lesions or papillary lesions that produce mucus or mucin that make a cyst. And this mucin or mucus that's produced in the duct, in the main duct of the branch, side branch, can cause pancreatitis. So there are circumstances where pancreatitis could make you think, okay, could this mean someone's prone to pancreatic cancer? That's something that I think about. If I see someone who's had pancreatitis, are there things where we need to think about pancreatic cancer or a precursor to pancreatic cancer up front to try to get it before it happens or as early as possible? Can kidney stones be a long-term symptom of Whipple? I have to tell you, I don't know the answer to that. That's something that I would have to look up. I can imagine that there's going to be variations in absorption. There are things that have variation in absorption as a result of a Whipple, including some heavy metals, for example, and calcium. And so the answer is probably, but I'm going to be completely honest with you. I can't speak intelligently enough about that to give you a really good answer, but it's something that I will look into. How often do you like to have follow up with patients post-Whipple? Again, depends on the circumstance. So if it's IPMN, it's a matter of surveillance imaging. As I mentioned at the beginning of the talk, the way it works in our system is that most of the follow-up really is done through the cancer center, through the surgery team. One of the members is a doctor nurse practitioner named Dr. Tanya Kintz, and she's phenomenal at kind of maintaining and following people afterwards. She's really amazing. She's really a godsend. She's amazing. And the team often will do their own follow-up and involve GI only on certain circumstances. So they're very, very good about doing that follow-up themselves. And that's circumstantial. So, often with most cancers, it's some kind of imaging, usually every year until at least 5 years. But I don't know what their protocol is right now with the Pancreatic Cancer Center. Can you consume alcohol post-Whipple wine in particular? That's a great question. I'm on the record here, so I have to be very careful. I think, as with everything, you have to weigh the risks and benefits carefully. And one, the risk of, will this have any meaningful negative impact on my life? If I don't have a pancreas anyway, right, Greg? Is this gonna hurt the pancreas that doesn't exist, right? Is this gonna be as carcinogenic as some people fear in terms of the pancreas in this setting? Will it lead to a higher risk of that? I suspect. I think it's like everything dose related. I think small amounts, if you're not susceptible or prone to liver disease, for example, if alcoholism was a problem prior to Whipple, for example, then obviously you would want to be careful with that. The easiest answer for a doctor to say is don't drink alcohol, but the reality is it's one of the risks is having an impact on social situations in life, enjoyment of life, if that's part of what you enjoy. And I think from again, I want to be careful because, but I think that if it's a matter of being careful and cautious and thoughtful, I'll tell you that often when physicians or hepatologists recommend complete cessation of alcohol, it's often because there's an assumption that no one can drink. People who are asking are not people that can just have a glass of wine here and there, right? But I don't think that's fair. I don't think that's true for everybody. And so I think I think it's circumstantial. I would say ask your physician is probably the safest thing for me to say. But my personal feeling is if it's done, if the dose is low, it's done in moderation. It's part of of an overall healthy lifestyle. Then I think being overly dogmatic about it probably actually does harm on some level to some people. But I'm sure there are other people who would disagree with me about that. And I'm not going to say that I'm 100% right, but I would say ask your doctor if they have strong concerns. Okay, maybe listen to that. But if it's if you don't have a pancreas and alcohol is not going to hurt your pancreas if you don't have a pancreas.
Okay. One
right?
of my doctors told me that the body can't process alcohol properly.
Yeah, that's true. Yeah, and that
it can become toxic.
Well, your liver is very good at being at dealing with toxins. The liver is your filter, right? Like this. When people talk about liver cleanses, these things are things that are not based in any science. The liver is the cleanse. Your liver is the cleanse. Processing or managing alcohol with alternate anatomy may influence its effect or impact or dose-related impact on your life. And often when people will make recommendations about managing GI symptoms related to a Whipple, it'll be minimizing or avoiding alcohol because of its potential impact on leading to different types of GI symptoms. So I don't know. I mean, I feel like I'm getting into trouble if I go too far on this. But I also kind of feel like not everyone's the same in terms of their relationship to alcohol, and some here and there. Who knows what that means? I think the safest thing to say is to avoid it altogether. But again, I don't know how based in science or research that is in terms of its applicability to everyone who's had a Whipple. I don't know how applicable that is to everyone in terms of will it actually harm you? Will it actually lead to symptoms or not? If it's a matter of symptoms, you have a glass of wine or half a glass of wine. If it doesn't cause symptoms, okay, be careful. If it's something where it actually causes injury, that's a different situation. Yeah, again, I would say ask your doctor for your particular circumstance. I'm someone who generally thinks people can be overly dogmatic for understandable reasons, but probably overly dogmatic. Is that a good non-answer? That's a good non-answer to your question.
Well, do you know, one of the things that I've kind of picked up on in the literature is the liver becomes kind of an important organ when you lose the spleen and the pancreas and everything else along with the package. And I've read a couple things that indicated that the function the spleen used to do ends up getting dumped on the liver to try to accomplish. And that can cause it can overwork the liver. And I've noticed since I had my Whipples, I'm developing fatty liver disease. And they said one of the things that can complicate that is, even moderate amounts of alcohol can
oh yes, that's true. Yes, no, I would definitely agree with that. I mean, I think if you have a susceptibility to that because of and this is something that I would ask the endocrinology team as well. If you're more susceptible to what would be commonly caused, a metabolic syndrome phenomena of insulin resistance, for example. So even the insulin that you get may have some resistance to this. And if that's associated with fatty liver disease, then 100% agree. Yeah, alcohol, you would worry that that you would go from having just a fatty liver to having it's called steatohepatitis or inflammation of the liver that could then lead to cirrhosis and other problems. So yes, yeah, that's why the safe answer of ask your physician about your personal circumstance is really important. I think yes, I think that's true, and I think that you have to be very careful within that setting.
All right, I'd like to switch gears and go to the digestive issue. And after I had the two Whipples, I noticed I had a lot of vitamin deficiencies. And we've tweaked them. We've tried all different kinds of things. I've got the vitamin D, the vitamin K, the vitamin Bs, all pretty much where they need to be. The only one I can't get anywhere near normal is the vitamin A.
Mm.
And I'm taking those senior multivitamins from Costco, twice a day. So I'm taking a double dose of those, and both have vitamin A in them. That didn't work, so I started taking a vitamin A supplement, and that didn't work. So we doubled it, tripled it, and then quadrupled it. That didn't work. So we went to a fat-soluble vitamin A and went through the same process, doubling, tripling, quadrupling. That didn't work. And on the theory that beta carotene breaks down in the body and part of it turns into vitamin A, we started off with a normal dose of beta carotene supplement and doubled it, quadrupled it now. And I'm about ready to go get another blood test to see if there's any input. But I believe the duodenum and the bottom of the stomach have a lot to do with vitamin A absorption. And with all of that tissue gone, is there a backdoor way of getting vitamin A? It's the one vitamin I don't know you can get as an injection, like you can get vitamin B and vitamin C supplements.
Yeah, I don't know. I don't know if there's an answer. I don't know of an answer in terms of getting vitamin A. I think that your experience, honestly, when I hear you describe the experience of trying this and then trying more, and then I'm sorry, my wife is asking for help with this.
Yeah, we've been working on it for about 2 years, and we still haven't gotten the vitamin A level above like 24 or 25, and that's below.
What I was going to say is, I think what's really interesting is your story, I think, reflects the reality of a lot of this space, which is that trial and error, trying something else, trying something different, because of a deficiency, not just in the vitamin, but in terms of our understanding of all the mechanisms that are involved. I think just as the question about pancreatic volume loss, pancreatic atrophy is an area that's a really good question. We should look into that. I feel like this is an area where, when people have, when people encounter these problems after surgery, it's kind of an opportunity to learn more about our digestive tract. I think what it reflects is that we have this much knowledge when there's, this much, beyond the screen that could be potentially had about things around us. And every time you learn more about something, you realize how little you know. Do you know what I mean? Like the deeper you get into it, the more you realize how little you actually know. The more you know, the more you realize you don't know. It's like it's the opposite of the Dunning-Kruger effect, right? Like or it's part of the Dunning-Kruger, right? It's the idea that when you know a lot, you're like, oh my God, there's a lot more here that I don't really know, that we don't know about. But it's an opportunity, I think, when people are experiencing things like this, to say, what does this tell us about vitamin A metabolism, vitamin A absorption? Is there something else we can learn about the GI tract? Is this kind of like the beginning of doing a research study to understand this a lot better for the future? That doesn't really answer your question, because it's a good question that I don't have an answer to. But I think, but that's the most kind of honest way I can approach this. And also just to point out that I think it's reflective of a lot of this field, and honestly a lot of medicine in general. I think it's not as precise a science as I think you think it is, until you actually get into it and you realize, boy, a lot of it is, there's a lot we don't know in general. And so maybe this presentation in 15 years will have a different answer to that question, but right now I don't have a good answer to it.
Good. Okay, Nancy has a question.
Yes.
Yes, it's Nancy's husband, Byron, here. First off, thank you, Doctor. This has been a fabulous, really a fabulous presentation. And I appreciate all the time you've taken, and the charts have been really helpful and detailed. And I feel like I've gone to med school with you a little bit. But I guess the quick question was, and my wife's just had, it was 4 weeks ago, Tuesday, that she had the Whipple surgery. And notwithstanding all the elements you've talked about, some of the difficulties, some of the long-term, maybe chronic problems, but just generally, she's still feeling some cramping and fat. What's sort of a guideline when you feel that some of those issues start to dissipate? Like, we're waiting for chemo, and the doctor has said he's never seen anyone do chemo till at least the 8 or 9 week period.
Mhm.
So is that, like, I know it's difficult to pin down and everyone's different, but have you found historically that it takes 8, 9, 10, 11 weeks before you're kind of quote unquote normal? Or anyways,
That's a really good question. I suspect that Greg and a number of other people here can give you kind of a perspective on how they felt throughout it. But as a general rule, you know, any kind of surgery in general is going to take just the pure healing process. There's kind of initial healing, like the initial kind of things coming back together at 24 hours. Things start to heal very, very quickly. You know, connections, surgical connections, you know, healing up of incisions and cuts and closures. There's an initial healing that occurs in 24 hours, but there's an ongoing healing process, just the healing process, that can take several months, you know, 2 or 3 months at least. Whether it's perceptible as symptoms or not, that's a difficult question to answer. But that healing process, putting down scar tissue, kind of finishing up the increased blood flow to these areas, you know, shifting blood flow from place else, can take several months to really fully play out. And then part of the healing process is not just the surgical side of it, but your body adapting to different flow of fluid, food, digestive enzymes, acid, more acid, less acid, bile, more bile, less bile, for example. And again, the body has a chance to kind of regulate this over time, you know, that can take several months to really kind of fully reach its new equilibrium. But I'd actually be interested to hear how other people have felt in terms
Thank
of
you.
Yeah, but 4 weeks to me is like, well, I certainly wouldn't expect there to be an equilibrium reached at that point. But I would be interested what other people feel in terms of their experiences after Whipple.
Yeah,
Thanks.
let me address that. When I had my Whipple, or was heading into it, I had a couple of mentors that had been through it before me, and they called it the 7 weeks of hell from the date of the Whipple surgery. And I was losing a pound a day afterwards, went down to 113 pounds, but it was quite accurate. 7 weeks before I started to feel better. And I remember the oncologist telling me that I couldn't start chemo until after I'd gotten past that basic recovery and had started to put weight back on again. I've watched a number of people coming up behind me, and several of them have managed to make it through that in about 6 weeks. But yes, 6 to 7 weeks. It's called the 7 weeks of hell that you have to go through before your digestive system really comes back online and gets efficient enough that things level out and you start putting weight back on again and can feel some strength recovery.
Okay, thanks, Greg. That's great. Good. Excellent.
Any other questions? All right, if not, we are going to wrap this up. Dr. Piraka, thank you. This was very informative.
Excellent.
Really appreciate it.
Thank you for having me. Really, genuinely, sincerely appreciate the opportunity, and it really is an honor to be asked to do this. And I don't take that lightly, and I really mean that sincerely. Thanks for the great questions and the attention and the interest, and I really, really hope that this was of some use and some help. That's really what I hope to have accomplished. So thank you again for inviting me. I really appreciate it.
Yeah, and if you see any areas that you think might be potential candidates for future research,
it's already in process.
Let us know. Annie would love to jump in on getting involved in some more research projects, with the Sky Foundation.
Great, that's great.
All right, thank you.
Thank you, everyone.
Thanks, everyone.
Bye, everyone.
All right, goodbye.